let me introduce you our last lecture at our webinar sessions. It is Miss Ana Janežić, who works as assistant at chair for social pharmacy, University of Ljubljana in Slovenia. She will be focusing on medication adherence as a key component of therapy, particularly in relation to her focus on outcomes in patients with hypertension and asthma, as very important topic also in relation to IPSF patient counseling event. So, Ms. Janežić, I will make you as a presenter right now, and you will see on your screen, and please share your presentation.
So, hello also from my side. I am very, very glad to be with you today. And so, first of all, I would like to thank the organizers for inviting me and giving me this opportunity to talk a little bit about medication adherence to you today. Before we get down to this topic of medication adherence, I would also just spend a few words on what I do and actually my story on how I came to the point where I am today. Just to give you a little bit of impression how you can become a teaching assistant and a researcher at the uni. That's what I do. So, just a second. I think I have some technical problems. All right. So usually the stories start with once upon a time, and if I'm about to tell my story about how I became a professional where I work, I could say that my story starts in 2004 in this building that you can see on the picture. It's the Faculty of Pharmacy of University of Ljubljana. So back in 2004, I started my studies to become a pharmacist. But to be totally honest, from the very beginning, I felt like something was missing, that I have to look out of the curriculum, you know, that I was bound to during my studies. So I started to search to be active in some other things besides my studies. And in my second year of study, I became involved in our local students association, and I was involved in different kind of projects. The first one, for example, was becoming a part of the organization committee of international summer camp for pharmacy students. But there is one particular project that I would like to point out about and maybe spend a few words on it, because it was really important to me. In a way, it shaped my future, and it made a huge impact on my perception of what pharmacy or pharmacist can be and can do in order to improve patient outcomes. So the project that I'm talking about is Healthcare Team Project. It was actually bringing together different future healthcare professionals. The core of the project were pharmacy and medicine students, but depending on the topic, also some other future healthcare professionals were involved and participated in the project. So what was basically the goal of the project was to emphasize the importance of different roles of different healthcare professionals, and to give the insight in that role in the healthcare team. And actually, the very important part of this project was like building some links between different healthcare professionals on the students level, and on the other hand also already on the professional level, because maybe some professionals who never met before, coming from different kind of fields of healthcare, actually maybe even learn about other professionals. And in that way, I think that the Healthcare Team Project really promoted the interprofessional collaboration, not just on the local students level, but maybe in a way also gave a very good idea about that also to the professionals who are already doing these kind of things in the practice. After that, I didn't really got involved in some other things. It was the thing that I was most dedicated to over a couple of years. After that, I was acting that for 3 years, and maybe that was also the reason that I never really decided to get involved internationally. So unlike other speakers, I was never really involved in IPSF. So maybe one thing that I can mention about IPSF, like having experience through IPSF, was the attendance of IPSF Congress in Bali, and the other experience through IPSF was the student exchange practice that I did in Coimbra in Portugal in the summer of 2010. So after doing the student exchange practice, I decided to take some more time to gain different experience in my life. So after that, I also took up a job as a student in a pharmaceutical company as a marketing assistant. I also finished my practical training for 5 months in a hospital. And after that, I decided to take a long trip. So I went to India and Sri Lanka for 3 months. And I think that all that, in a way, contributed to and shaped me as a person and as a future healthcare professional. And after all this, I came to the point where I could really say, okay, it was enough. I have the experience. I got the experience that I wanted. And now I can really devote myself to do the master thesis. So after that, I took additional year to do the research for my master thesis. And then at the beginning of the year 2012, you could say, finally graduated. So have a look at where I am now. Here you can see the very same building on the picture that I showed you in the first slide. So if you're asking yourself, why do I keep showing you this picture, is because I'm still spending my time here, just maybe in a little bit different company than I did in my students' time. So who I work with, this is the team of the chair of social pharmacy. These are my co-workers that I work with on a daily basis. It was a very interesting let's say, shift in my thinking of what I want to do with my life in the sense of being a professional. Because since I got involved in healthcare team project, I was 100% sure that I want to be a clinical pharmacist. Because at that time when I was active in that project, it was basically the time when I actually discovered clinical pharmacy, which wasn't something really really developed at that time in Slovenia. So it was quite a discovery for me in a way, what can pharmacist can do and what can his role in patient care be. So from that point on, I was like, I'm gonna be a clinical pharmacist and that's it, that's my future. So when during my research for the master thesis, the offer of the now boss, at that time he was still my mentor for master thesis, when the offer to get the position of teaching assistant came up, it was quite a challenge for me to decide what I want to do. But before the offer came up, I never really thought about being like staying in the academia, you know. But during the research for my master thesis, I realized that the research is really something that I like, that it challenges me, that it feeds my curiosity, and in that way I really could imagine myself doing that, at least for a while. I wasn't really sure to stay in academia like forever or something, but it was something that really felt right at that time, and it was really something that I became really interested in. And in addition to that, I really wanted a job that actually would challenge me, and I wanted a job that would support me in developing my knowledge and developing my skills. And basically, when that offer for this position came up, in a way, it wasn't even a very difficult decision to be made, so I accepted it. So the organizers also asked me to say a few words about how my usual working day looks like. Well, I'm afraid it's very difficult to describe it, because there is no such thing as my typical working day, because my work basically comprise of 3 different parts. My main role is teaching, so I teach students on patient counseling, medical statistics, and evidence-based medicine, public health, and so on. So this takes quite a lot of time, but for sure the other very, very important part of my work is also research. So my research focus is, like Dalia mentioned at the beginning, is medication adherence. So you can imagine that this kind of research doesn't really require a high-tech lab and being in a white coat and having gloves and so on, but it requires a computer, a good computer. So usually I look like that, the person on the picture, and then you need some kind of a setting where you can actually recruit the patients, because if you want to deal with medication adherence, you for sure need patients. And so these 2 pictures are actually my research in a nutshell. So what research that I do looks like? Basically, a very important part of that is being up to date with the research that is going on, the studies that are being performed and published in this field, so you can see what has been done, and maybe in that way you can create new ideas, new research questions, and when you manage to come up with something that might be interesting to research about, it is up to decide what kind of a protocol you would use. So you have to decide about study design, you have to decide about methods you would use, and then actually to conduct the study. And at that point, it's not over yet. You have to also know the statistical analysis methods to perform statistical analysis, and that for sure the story doesn't end here, but you have to also disseminate the results in the form of a research article or present it in international conferences or in some other portfolios. So the third part of my work is being involved in projects. Mostly I get involved in pharmacoeconomic projects, because cost effectiveness studies are a very important part of health technology assessment, which is then again a part, like we could say integral part of health policy making. So in a way it's quite important, and it's a very good feeling that you can in a way contribute to the health policy making in your country. Like I mentioned before, the crucial part of research is also the dissemination of the results. So that's why I usually go to international congress once or twice or even 3 times per year, where you can meet people who do the research, you can discuss the results, discuss the methodology, and you can also learn a lot in that way. Probably you're thinking right now that congresses for grown-ups have to be really, really boring while you are looking at these pictures of me standing beside the poster, but and you are comparing the picture to that one that I showed you before from Bali. But I can assure you it's not just standing by the poster. It's also a lot of other interesting things that are going on the congresses that I attend. The congresses that usually cover the topics of clinical pharmacy, of medication adherence, or patient pharmaceutical care research. So I think that it's very, very important to share the results, to discuss it with other researchers. But even for me, more important than that is to present the results to the healthcare practitioners, because that kind of research that I do is actually meant for healthcare professionals in the end. I believe that the research has to be applicative for the healthcare per se, and I have to say I was really, really lucky that I got the opportunity to present the results of my study that was about medication adherence and health outcomes in patients with asthma and COPD to a very large number of pharmacists and lung doctors in Slovenia. And for me, that was a really, really big success that I could distribute my results to them and link research and healthcare practice on the other side. Okay, so let's stop about me and move on to medication adherence, which is today's topic of my speech. First of all, I would just like to make clear what adherence is. Probably you could find various definitions on that, but I prefer to stick with the WHO one, which says that adherence is basically the extent of which a person's behavior corresponds with agreed recommendation from a healthcare provider. So we can talk about taking medicine, we can talk about following a diet or some other things like lifestyle changes, but usually since we are pharmacists, we do focus on medication taking and therefore talk about medication adherence. There is another thing that I would like to emphasize in this definition, because we are not always aware of the fact that the relationship between the patient and the healthcare professional is very, very important. And also, this is the part of definition that WHO actually came up with, is that the patient behavior doesn't really have to completely match with the instructions given by her healthcare provider, but has to agree with agreed recommendations. So it does emphasize this need for agreement, the need for collaboration between patient and healthcare provider on the other side. So since I'm a very passionate swing dancer, I'll allow myself to do the following comparison. So you can imagine two people dancing. One is always a leader and the other is follower. Usually a guy is a leader and a woman is a follower. And you could easily compare the dancing couple to the relationship of a patient and healthcare provider. Because in a way, in a dancing couple, you would expect from a leader to be leading, to be responsible for nice, fluent dance through the music. But at the same time, you have to be aware that the leader cannot just push the follower and force her to dance. He can just ask her to dance, invite her to dance, and then at the same time he has to make sure that the follower will be able to follow him and that she will agree with the style of the dance he will propose to her, and that she will agree about the music he will propose to dance to, and that if maybe somewhere on the half of the way of the song, if she will, let's say, give up on dancing, that it's in a way his responsibility to try to motivate her to dance with him till the end of the song. So in a way, the relationship is quite similar to that one between the healthcare provider and patient, and maybe you will understand this comparison a little bit more later on throughout my presentation. So medication adherence or non-adherence can be manifested in very different ways or forms. Here we have some examples of patterns of non-adherence, and if you can imagine that each line represents each patient, and you can see that each line is there are days that are going from 1 to eternity, if possible. You can try to understand that each white circle is a day when the medicines were not taken, and each gray circle was the day when the medicine was taken. So in the first line, we can see the patient who is not taking his medication, and he never even started taking his medication. So this is a very, very poor medication adherence, and we would never want to have a patient like that. And then in the second line, we see that all the circles are full, so we can basically say that we have a perfect adherer. We have a perfect patient, and this kind of patient we would always want to have as a healthcare professional. What the problem is that there is no such thing as a perfect adherer in the real life, because nobody is able to adhere 100%, because everybody will fail to take all the doses and will at least forget to take those of their medicine from time to time. Then in the third line, we have, as we can see, some of the doses that are missing. We could easily assume that the patient is just forgetting to take medicine now and then. Then in the fourth line, we can see that the patient was taking his medicine, and then at some point something happened and the medication adherence stopped. So we can see that the patient quit taking the medicine and did not start to take medicine again. And then in the bottom line, we can see that there is a special pattern going on, because you have 5 full circles and then 2 white circles and then 5 full again, and so on. And you can actually see that there we have a patient who is only taking his medicines throughout the working days of the week, and then over the weekends he doesn't take his medicine. Well, in English we do have a word for that. It's called drug holidays, and it's not that rare as you might think. Maybe the previous slide already gave you the idea that that medication adherence have different aspects, because we could see that some of the patients in the previous slide had the problem with initiation, and then some of them had the problem with implementation part of the adherence, and then one of the patients had the problem with persistence. That was the one who started to take the medicine and took it very regularly, and then at some point he just stopped. That was a patient with poor persistence. We can see one or more of these aspects of non-adherence in a patient. So here we have some more examples. If you try to understand that the blue dots are the doses taken, and gray columns are the days when the doses were missed. You can see that in the first case, the patient A on the top, we can see a lot of gray columns at the beginning, which means that the patient did not start taking the medicine right after he was prescribed one. So here we can see late initiation, but after that, after he finally decided to start his medicine, his implementation part of adherence was pretty good. And then in the patient B, we can see that initiation was good. The patient started to take his medicine right away after it was prescribed. And then after some time, issues came up, and luckily he managed to overcome it, but still the implementation part was not that good. It was suboptimal. And then in the case of the patient C, we can see that initiation was good, implementation was good, we could say excellent, but also here at some point in time, the patient just decided to stop his medicine, and therefore we could say that the persistence was not so good, and it was a problem. So, like I said before, there is no such thing as a perfect adherer. People usually do skip the doses, and that's why the adherence typically ranges from 0 to 100%. But then, for sure, we have to pose a question. What rate of adherence is still acceptable? Because it's not the same if the patient misses the dose once per month, for example, or if he misses his dose a couple of times per week. So the study suggests that the acceptable rate of adherence is 80%, which means that if a patient misses less than 20% of his doses, then this should not have any serious consequences. But if he misses more than 20% of the doses, this might lead to suboptimal health outcomes. And at the same time, we have to keep in mind that with some specific therapies like HIV patients, the required adherence rate is much higher than 80%, and in HIV patients, it's at least 95% adherence required. On the other hand, some patients might take more medication than they were prescribed, and in that cases we could say the adherence is more than 100%, and it's not maybe a very good idea because the effectiveness is not a problem, but we can easily come up with safety issues. So the question is, how common is non-adherence? If you would want to guess from this number of people that you can see on the screen, how many of them are being non-adherent, or in other words, they are not having an acceptable rate of adherence? The answer is around 50%. And when we are talking about 50%, we are talking about chronic diseases and in developed countries, because in developing countries the rate of adherence tends to be even lower because of poor healthcare resources and poor access to healthcare. So non-adherence is not just black and white. We can never just say this patient is adherent and this one isn't. But it has a full range of variation between that black and white, and there is a quite interesting information data that I found in one of the articles, that we could divide patients in six. You know, that 1 in 6 is almost a perfect adherer, then 1 in 6 is basically not taking medication at all, and there is a wide range of different kind of behaviors in between that we have to pay attention to and take some measure according to what kind of a patient that we actually have in front of us. So there can be quite a large variability also between different health states regarding medication adherence. Just to give you a little bit of impression, let's have a look at this table on our left-hand side. It shows the results of meta-analysis of Di Matteo. And here we can see that patients who are treated for HIV, arthritis, and GIT disorders and cancer are those who adhere to their therapy the best. And on the other hand, patients who are the most troublesome in this regard are those receiving therapy for diabetes and pulmonary diseases such as asthma and COPD. And the reason for this poor adherence in these patient groups might be maybe a little bit more complicated route of administration of medication that are prescribed for these patients. And on the right-hand side, you can also see a figure that shows you how is persistence in different kind of therapies. And you can see that, for example, even patients who survived a stroke after 2 years, only around 40% of patients is still taking their warfarin, which is somehow very troublesome. So we were talking about how medication adherence is quite common, but let's just ask ourselves, why is that a problem? Why should we bother about non-adherence? If we try to remind ourselves about the quote that I posted as my first slide when I started talking about medication adherence, you can maybe remember about the quote that was on that slide from Dr. Koop that said that drugs don't work in patients who don't take them. Well, Dr. Koop was right, and we can actually easily guess that non-adherence is leading to poor disease control, that those patients who are not taking their medicines will typically have more complications of the disease, more frequent exacerbation of disease, they will be more frequently hospitalized, and for sure non-adherence is also linked to greater mortality of those patients. We should also at this point mention the contribution of medication non-adherence to antibiotic resistance, which is also a very, very big problem all over the world. And for those of you who like to have a bigger picture, we have to keep in mind that this non-adherence and everything that it's linked between to non-adherence costs a lot of money. If you just have a look at costs that are being estimated for the USA, they're saying it's around 100 billion per year only for the USA as a result of medication and non-adherence. So now I was talking more about the problem of effectiveness, but there are also problems with safety, because especially if there are treatments that require slower discontinuation, step-by-step discontinuation, for example, like beta blockers or some antidepressants. If the patient just decides to discontinue the treatment without any consultation with a healthcare provider, that might result in a withdrawal syndrome, or patient might suffer from rebound effect. On the other side, if patient is not following the instructions on how much medication he has to take or can take, and for how long it is advisable to take the therapy, he is risking addiction, for example with opioids, or he's risking adverse drug reactions, or even in worst cases, toxic effects of the medicine. Quite a big challenge is to identify non-adherence, so let's have a word about how to assess medication adherence. So one very useful, effective method is direct observation of treatment, but basically that can only be used in the studies. It's not feasible in clinical practice. Then another quite objective and maybe also a little bit demanding method is measurement of plasma or urine drug concentrations. We can maybe assess medication adherence a little bit in a different way through measurement of physiologic markers. We could use electronic medication monitors. We could perform a pill count or use medication refill data. We can always rely on a patient and assess medication adherence using validated questionnaires, patient diaries, and things like that. So now let's meet Mr. Bob, who is a very kind old gentleman. Mr. Bob is receiving 3 different medications. He's having his antihypertensive agent that he has to take in the morning. Then he has 1 medicine for his diabetes that he has to take 3 times per day. And then he has a lipid lowering agent that is supposed to be taken in the evening. So we might ask ourselves, do you think that Mr. Bob has any kind of problems with medication non-adherence? Well, if you had a little talk with Mr. Bob, you could realize that in fact he does. You could find out that he forgets to take metformin occasionally and that he refuses to take atorvastatin due to fear of possible side effects. So in this case of Mr. Bob, we can talk about 2 different kinds of medication adherence. First is intentional, because he actively decided not to take atorvastatin because he was afraid of possible side effects. And on the other hand, we could talk about unintentional adherence, which is more of a passive process and is usually run by the barriers that prevent the patient to follow the instructions, even if he wanted to. So in this particular patient, we have both types of medication adherence, but that's not necessary. Maybe in some patients we could only find one type of adherence. So there can be numerous factors associated with non-adherence. We could basically divide them into 5 different groups. A lot of factors arise from patient himself or herself that are related to patient's beliefs, perception of the disease, also maybe some concerns that the patient can have about the proposed therapy. Then we can talk about socio-economic factors that are usually related to patient his economic position, his level of education, his health literacy, his, let's say, language barriers and things like that. Then we can talk about condition-related factors that is usually related to the characteristics of the disease. For example, patients who are having asymptomatic course of disease are typically less adherent than those who feel that they have something, that something is being going on with their body that is not okay. And depression is also a very strong predictor of non-adherence, because patients who have the depression are not only being poor with adhering to antidepressant therapy, but also about the full therapy that they are prescribed. Then we can talk about treatment-related factors, especially if the treatment regimen is very, very complex. if a patient has a lot of drugs, if there is a lot of doses that have to be taken throughout the day, let's say in the morning and then in the middle of the day and then again in the evening, that can be very, very burdensome for a patient, and he might not be able to follow it anymore. And then we have factors that are healthcare system related, and basically they are related to the quality of communication between the patient and healthcare provider, and the access to healthcare that the patient has or doesn't have. So I would like to end with a thought of what can we do to enhance medication adherence, because we can see it's quite a big problem, but is there something that we can do? Just a minute ago I was talking about different factors that contribute to medication non-adherence, but basically we could narrow it down to 3 core components. It's about if a patient is educated enough, if he has enough knowledge about his disease and about his therapy, whether he has enough motivation to follow the treatment that is proposed to him, and if a patient has the ability to follow the treatment. And probably the first thing that we would like to address, or we can address actually, is the patient knowledge and patient motivation. We can use different kind of approaches to increase patient's knowledge about his drugs, about his disease, and for sure there are some very, very effective ways of motivating the patient. For example, motivational interview is one of those. So there's another option of addressing medication non-adherence, which is optimizing a therapy. We might want to optimize it in a way to become more patient-friendly. If, for example, patient has side effects, we would change the medicine for some else that would not cause the side effects to a patient. If a patient doesn't like the prescribed time of taking the medicine, we can say that if he doesn't like to take it, for example, in the evening, he might take it in the morning, so we can just a little bit adjust the regimen to fit into the patient's schedule a little bit better. Then we can introduce the fixed combination drugs, which means that one pill has, for example, 3 different active ingredients instead of just taking 3 different drugs, which might be, again, very burdensome for a patient. And then we can give a patient maybe a drug that has longer half-life, which will enable less frequent administration, and so on. So there are some options. Maybe some of them are not possible to be performed by a pharmacist, because at least in Slovenia we don't have a right to prescribe the drugs, but maybe in some other countries that might be different. But even though we can always at least try to optimize medication regimen and to make it more patient-friendly. And then for those patients who tend to forget about taking their medicines, there are a lot of options that can be advised to them, to remind them, to help them to remind to take their medicine. If we are dealing with younger patients, maybe we can advise them to search for an app that would fit the purpose and it will help them to remind to take their drugs. And if we are dealing with older patients, that might not be the right solution for them. In that case, we would rather advise them to use, for example, pill boxes, which were found to be quite successful in that. So if I wrap up, I hope that you got the impression that non-adherence is a very common thing. It's a big issue, and it's a very complex issue that it's not very easy to be solved. Increasing adherence may actually have a greater effect on health than improvements in any specific medical therapy. This point was not really something I came up with. It's one of the WHO statements that they posted in their report on medication adherence, so you should believe them. And then the final thing I would like to point out is that we all have to play our role as we are supposed to. We have to try our best to help the patients in their following the therapy, and sometimes it's not possible just the problem to be solved by only one healthcare professional. So interprofessional collaboration is very important as well, and I think maybe we should work on that a little bit more in the future. So I would like to finish with this, and I will be very happy to answer some questions if you are interested in anything more.
Thank you very much, Ms. Janežić, for this wonderful lecture. And of course, we have a few questions. You have one question. You mentioned the key to patient adherence to medication is to have an agreed recommendation with a healthcare provider. As pharmacists and healthcare providers, what is the implication for us? Wouldn't be a deviation? Wouldn't that be a deviation for the from the prescription?
Well, maybe I was a little bit misunderstood. Well, for sure, if a patient comes with a prescription which tells you which medicine you have to dispense and in what, in how many milligrams and how many doses per day the patient has to take, it's not for sure up to us to decide and override the doctor's instructions. But at that point, when the patient is at the doctor's office and they're discussing the possibilities of the therapy of the disease that the patient has, at that point there is some place for the agreement that can be made between them, because I think that it's very common for a patient that comes in the patient's room, you know, and then at the doctor's room, and then the doctor tells him that he has this and this kind of disease, and he would just tell them, okay, from now on you have to take this drug, and he wouldn't really pay attention to the fact that the patient might not want that drug, that maybe this is not the best drug for the patient. So sometimes there is not a lot of possibilities. There is not an alternative. There is only one drug that is objectively speaking best for the patient. But if we go back to the relationship between pharmacist and the patient, for example, that's one of the examples that I gave just before. Let's say if a patient is taking the statin that's supposed to be taken in the evening, and the patient would complain that he would always forget to take the statin because it's very inconvenient for him to remind and take the pill in the evening, and he would assure you that if he could take the statin in the morning with, for example, let's say his antihypertensive drug, that he will never forget to take it, then of course you would try to make recommendation that would also be acceptable for a patient. And if he would really want to take that pill in the morning, I see absolutely no reason that you would make this agreement with him. So did I explain it? Did I answer it?
I believe you did.
Okay.
So thank you. Thank you for your answer. We have one more. What is the difference between adherence, compliance, and concordance?
Well, basically, a lot of people doesn't really tell apart that these are different kind of words with a little bit different kind of meanings. Well, most often you will find compliance in not very up-to-date literature, while adherence is more often found in more recent literature. What is the difference between compliance and adherence? Here we can go back to the dancing part that I had at the beginning, because compliance is actually assuming that patient is in the passive role, that his duty is just to follow the instructions given by the doctor, and for me it has a bit of a negative connotation because of that, because it doesn't presume any kind of collaboration, any kind of partnership. While on the other hand, adherence does. That's why I was trying to emphasize that agreed recommendations, because in adherence you have this more positive connotation of partnership hidden into this expression of adherence, contrary to compliance, like I mentioned before. But again, both of the words are actually dealing with patient's behavior, what he does about taking the medicine, whether he does take the medicine or not. Because on the other hand, concordance is something a little bit different, because it doesn't really talk about patient's behavior, but it actually does talk only about the relationship between the patient and the healthcare provider. And if we say that there is concordance being present, then we can say that there is a partnership being present between those two, so the patient and the healthcare provider. That's maybe the difference in short.
Thank you for your answer. And we have one more specific question. How can we enhance an Alzheimer's patient adherence because he or she refuses to take a medication?
Well, the Alzheimer patient, so can you just repeat the question, please?
How can we enhance an Alzheimer's patient adherence because he or she refuses to take a medication?
Well, when we are dealing with intentional non-adherence, it's very, very hard to enhance medication adherence. Very often we have problem with dementia or Alzheimer's disease because people also forget to take the medicine. Even that can be a problem. But when we are talking about patient refusing to take the medicines, actually the problem is even bigger, and the challenge is even bigger. Well, I don't think it's really important about which kind of a disease we are talking about, because when we are dealing with intentional non-adherence, it's very, very important to go into details with the patient, to make sure that we totally understand why does he refuse to take the treatment. What are the underlying reasons for that? And only after you understand that very well, you can maybe work on enhancing the adherence. Because always the intervention has to follow the underlying reasons for that. You cannot just do some intervention and hope it works, but it has to be tailored to this specific individual that you're dealing with. So it's very hard to say what to do with this particular patient to make him use the medicine, because I don't know what is the reason why he refuses to take the medicine. So if we had maybe a little bit of background of this patient, it will be much easier to say something more concrete.
Thank you for your answer. One more question. We as pharmacists in the community pharmacy sometimes tend to catch a paternalist attitude in counseling and in guiding the patient to achieve good adherence. So what other attitudes or strategies we can use to be assertive and be useful to patients to achieve good adherence?
Yes, I think that paternalistic approach is still very, very present, either among doctors as well as among pharmacists. But I'm not sure if it pays off, if it really works, if you do achieve better results with the patient, if you achieve a better adherence. Because usually what you would actually achieve is that patient wouldn't really want to speak his mind to you. And that is not something very good. Most probably you have to show some empathy, you have to show that you are willing to listen, you have to encourage patient to actually talk to you. Because I think that in many cases, at least from what I see in pharmaceutical practice in Slovenia, a very common thing is to see a patient, just standing in the pharmacy in front of the pharmacist, and he doesn't really get to say a word to a pharmacist. He just gets the instructions, gets the medicine, and then he leaves the pharmacy. Because it's up to a pharmacist to take the responsibility to start the conversation and to actually give the patient the opportunity to speak for himself, to express himself, to express maybe his attitudes towards the disease that he has, and maybe his beliefs that he has about his medicines, or concerns that he has about his medicines. And only after you achieve this kind of a level of communication with the patient, I think that the communication can be successful, and it would probably lead also to better patient outcomes through time with this particular patient. So it's about empathy, it's about being actually willing to help the patient and being willing to listen to him, and not just tell him to do things or demand from him to follow your orders or instructions that you're giving to him, or you're just maybe taking it from the doctor and then passing it on to a patient. So there are more kind of a partnership approaches that I just talked about, and I think that are more effective than more paternalistic approach. And also in the end, I believe that both of the persons that are involved in this kind of communication feel better after the communication is finished. The patient, when he goes out, feels probably much better if he had a feeling that the pharmacist was actually listening to him. And I also think that the patient would respond in a better way throughout this kind of conversation. And then probably in the end, also the pharmacist will feel better after this kind of conversation, instead of just having a patient on the other side standing like a wall without saying anything. So this is maybe my advice to approach to a patient.
Thank you for your answer. And final and last question is, at the end, as we are celebrating women and girls in science as successful young women, say something inspiring and feel free to say any closing statements you want.
Oh, that's a very hard job that you just gave me. So yes, I think that your initiative is very, very good, and I have to say I support it very much. Well, I'm not sure that I have been very much feeling any kind of discrimination upon my gender, that I would be like discriminated because I was being a woman. I did feel some, maybe, let's say, discrimination because of my age, because if you are younger and looking younger, then sometimes people think that you are totally unexperienced, that you don't have any knowledge, that you don't have any skills. So, like already Tana said before, I think that you have to fight that. That you shouldn't really take it to your heart too much, because maybe for the first time when you hear something like that, it can really, it can really feel bad. But you shouldn't really feel bad about it. You should take it as a, what doesn't kill you makes you stronger style. And you should have to have faith in yourself, and just do what you want, because it doesn't really matter if you're a woman or you are a man or you are something in between. You can be very successful. You can achieve anything you want, and don't really allow anyone to stop you just because of that. So I think this is it.
Thank you very much again for your lecture, and at the end, so I would like to thank you all for the participation this night. It was really my pleasure to moderating this event, and I hope that you all enjoyed in all of these lectures we provided, and I will ask now Luca to close webinar sessions officially.
Thank you very much, Dalia. Thank you to Anna and all the speakers, to all the participants. I really hope that you enjoyed these sessions today and yesterday. You might have noticed that, for example, the last session yesterday was touching a bit on the pharmacy workforce development goals, and we try to continue with that also today with the UN Sustainable Development Goals from Tana, and also wrapping up the whole webinar sessions with promising young scientists to really show you that there exists great variety in the field of pharmacy, in basically the paths you can take to become, to build your own careers. And I hope that besides learning lots of new interesting information about different topics, that you also were able to get a bit of an insight into what you want to do in your life, to feel motivated. And also we did receive a lot of questions on all the speaking sessions. Unfortunately, there was not enough time to go through all of them, but still we hope that the questions that were given did help you in the end to perhaps know a bit more about certain decisions you want to take and what you want to pursue in your life. So thank you again, and we will see each other in the future as well, I'm sure of that.